Thanks for having me here today. My talk is going to focus on the management of patients for open thoracoabdominal aortic aneurysm repair. This will be one of the more complex vascular surgical procedures that patients will undergo. I have no financial disclosures to make with respect to the content of this talk. And I'd like to motivate the talk with a little bit of a case vignette. This is a 65-year-old male you're being asked to take care of. He's got a history of hypertension, hyperlipidemia, tobacco use, and who's presented with a 7-centimeter type 2 thoracoabdominal aortic aneurysm. In the inset of the slide, you can see a 3D reconstruction of the CT angiogram, clearly illustrating the tortuous and dilated nature of the patient's descending thoracic aorta as well as abdominal aorta. This patient presents for open thoracoabdominal aortic aneurysm repair with left atrial femoral bypass. And it's noted that a CSF drain is requested to be placed and motor evoked potential monitoring will be used. So what I'll do in the remainder of the talk is focus on a little bit about the surgical procedure, what's involved in the actual repair itself, and then talk about some of the management features that are unique to this type of case, specifically looking at means of spinal cord protection with CSF drainage, means of visceral organ and cord protection with distal aortic perfusion, as well as the use of motor evoked potential monitoring. So by way of background, thoracoabdominal aortic aneurysms are a relatively rare occurrence. It's estimated that there are 6 to 10 per 100,000 people per year. Typically, they present in the 6th to 7th decade of life. And here we're specifically talking about degenerative aneurysmal disease and not aneurysmal disease associated with any sort of genetic or connective tissue disorder. Risk factors are similar for most peripheral vascular disease, consisting of hypertension, hyperlipidemia, COPD, history of tobacco use, family history, as well as obesity. Typically, they're classified based on the extent and location of aneurysmal dilation using the Crawford classification, which is illustrated in this slide. So the traditional Crawford classification has 4 types of thoracoabdominal aortic aneurysm. Type 1 is aneurysmal dilation of the aorta from just distal to the left subclavian artery, extending all the way past the visceral arteries in the abdominal aorta. Type 2 is the most extensive type of thoracoabdominal aortic aneurysm and essentially consists of dilation of the aorta from distal to the left subclavian artery all the way to the iliac bifurcation. Type 3 is dilation of the aorta starting at about the T6 level down to the iliac bifurcation. And finally, type 4 is dilation of the aorta that starts at the level of the diaphragm and extends to the iliac bifurcation. An additional type was recently described that starts from T6 and extends to just distal to the origin of the visceral arteries, and it's cited as or known as type 5. But most of the literature uses this classification system that's presented here. So with respect to indications for open repair, the indications for repair in general for this type of disease is the presence of symptoms. So in other words, back pain or evidence of extravasation of contrast on imaging, and also related to the size. So diameter greater than 5.5 centimeters or an increase in the diameter by over 0.5 centimeter over the course of a year. The figure on the right is a graph from a recently published review of distal and thoracoabdominal aortic aneurysm repair from the Cleveland Clinic. And it serves to illustrate the fact that over the last 20 years or so, more and more of this disease is being treated with an endovascular approach. So what this illustrates is over the course of the study period, which was 10 years, the percentage of thoracoabdominal and distal thoracic aortic aneurysms that were repaired at Cleveland Clinic using an open approach. And as you can see that over the course of the last 20 years, there's been a significant decline with many more of these procedures being done through endovascular means using either stent grafts for distal thoracic aortic, descending thoracic aortic disease, or fenestrated grafts for disease involving the viscera as well. However, the need for being able to conduct an open approach still persists. And in general, when a patient's anatomy is unsuitable for an endovascular approach, in other words, there's not enough of a landing zone or zone of normal aorta to anchor the stent graft, or there are issues with vascular access, for instance, tortuous or really calcified iliac or femoral arteries, then an open approach is necessary. Likewise, if there are any complications following endovascular repair, which tend to manifest over a longer period of time in the form of endovascular leaks or continued expansion of the aneurysm, there's an indication for open repair. So the next few slides, what I'll do is go over the steps of the surgical procedure, because an understanding of what's happening surgically will greatly inform the anesthetic approach to managing these patients. The patient's position is illustrated in this slide, and the size and nature of the incision, a large thoracoabdominal incision starting from the back, extending anteriorly down the abdomen, provides excellent exposure or access to the retroperitoneum, where the aorta itself is located. So once the aorta is dissected out, then the surgeons will establish typically left atrial femoral bypass, and that's illustrated here. In this case, the bypass circuit runs from the left atrium to the descending aorta. It can also be placed into the femoral artery, and we can discuss the use and details of distal aortic bypass or atrial femoral bypass further on in the talk. Bypass is initiated, proximal clamp is placed, a distal clamp is placed that's partway down the aneurysm, and then the aneurysm sac is opened. Once the sac is opened, intercostal arteries are suture ligated, and a graft that's illustrated here, a Dacron graft with limbs constructed for the various visceral bypass is inserted. Proximal anastomosis is conducted as illustrated, and once the proximal anastomosis is complete, then the proximal clamp is moved onto the graft itself, and further dissection of the remainder of the aneurysm takes place. Not illustrated here are clamps on distal to the distal extent of the aneurysm to prevent retrograde blood flow into the field. We'll talk about motor evoked potential during the course of later on in this talk. But if in the course of this procedure, there's evidence that certain intercostal arteries require continued perfusion after graft placement, hole is made in the graft, which is then sutured around the origins of these arteries, such that when blood flows through the graft, those intercostals are also perfused. Perfusion to the visceral organs can be maintained as illustrated here with limbs coming off the atrial bypass circuit. Likewise, cold crystalloid is perfused into the renal arteries to help reduce renal dysfunction post-op. So as you can see in this image at this stage in the procedure, the intercostals have been incorporated, the proximal anastomosis is complete, and work begins on the distal anastomosis. After the distal anastomosis is complete, then work begins on the grafts, ultimately leading to replacement of the thoracoabdominal aortic aneurysm with bypasses to the visceral. So with respect to patient preparation, like most vascular patients, they require extensive history, physical exam, complement of lab studies, and then cardiac and ancillary studies based on the patient's history. With respect to patient risk factors for outcome, this is a relatively recent study, single center retrospective trial from Hopkins reviewing about 1,000 open thoracoabdominal aortic aneurysms. They reported a perioperative mortality of 11% for non-ruptured cases, 34% in the instance of repair of ruptured thoracos. And what they identified were factors that affect the mortality. The largest effect was based on the patient's ability to carry out activities of daily living. So complete dependent status conferred a three times increased risk of mortality. Other risk factors included ruptured status of the aneurysm, the presence of perioperative renal insufficiency, and there's increasing risk with increasing BMI and increasing age of the patient. As far as lines, monitors, and equipment, volume access is paramount. Blood pressure can be monitored proximal to the clamp, so to the head using right radial A-line. A right radial A-line is placed on the right side in case the left subclavian artery has to be clamped, or the proximal clamp has to be placed proximal to the left subclavian artery. Right femoral arterial line is placed to be able to monitor organ perfusion pressure during distal aortic bypass. And then, depending on the institutional culture and preference, pulmonary artery catheter may be used, as well as transesophageal echo. Furthermore, for cord preservation, CSF drainage catheter is placed, and then rapid infuser and red blood cell salvage is also used. With respect to the anesthetic itself, the technique typically involves a TIVA with the avoidance of neuromuscular blockade. This is to facilitate motor evoked potential monitoring. Lung isolation is required. So one lung ventilation of the right lung to allow full access to the left thorax. Renal protection will be discussed later, and then spinal cord protection techniques, including CSF drainage, distal aortic perfusion, and motor evoked potential monitoring. So briefly regarding lung isolation, options include double lumen tube, which provides greater flexibility to either oxygenate or provide oxygen to the collapsed lung with a form of CPAP, or to suction the collapsed lung. The downside to using a double lumen tube is it'll require replacement at the end of the case, and these are typically cases on the order of 6 to 10 hours with the head in a dependent position, so really a demonstrative airway. One caution with the left-sided tube is illustrated in this CT angiogram from a case report. Here you see in the sagittal section, extensive thoraco-abdominal aortic aneurysm, and in a cross-sectional view, this is the aneurysm sac, and you can see that it's actually compressing the left main stem bronchus, making it difficult to actually pass a double lumen tube. An alternative to double lumen tubes in these cases, the use of a bronchial blocker, illustrated here. The advantage is that tube change is not required at the end of the case. The blocker can just be removed. However, the downside is if this situation presents itself with a compressed left main stem, it will also be challenging to place. We'll talk briefly on renal protection. Post-op AKI has been reported in the literature to occur anywhere from 20 to 60% of cases. 3 to 11% progress to renal failure requiring either temporary or permanent dialysis. And the presence of it post-operatively is associated with reduced survival, both in the immediate post-op period and up to 5 years. Risk factors for renal dysfunction after the procedure include preoperative renal function, the emergent nature of the surgery, extended cross-clamp time, and advanced age. One of the techniques that's commonly used to help mitigate or reduce the incidence of renal injury during these cases is the perfusion of cold crystalloid directly into the renal artery when the visceral portion of the aorta is open and there's no longer any distal aortic perfusion, and that's illustrated in the graphic on the right here. So the earliest trial to show the benefit of this was a randomized controlled trial in patients undergoing open type 2 thoracoabdominal aortic aneurysm repair with distal aortic perfusion. It enrolled 30 patients who were randomized to receive either 4 degrees centigrade lactated ringers or warm blood directly into the renal artery, as illustrated here. And the outcome measure was the incidence of acute renal failure that they described as greater than 50% increase in creatinine above baseline in 10 days. Here you see the results slide from that paper, and it's notable that there's a reduction in significant renal dysfunction from 63% to 21% with the use of cold crystalloid perfusate. The same study was tried, the same group tried a similar study a little bit later on with more patients where they did cold saline or cold crystalloid and cold blood, and found that there was no difference in outcome. Both served to reduce renal insufficiency post-op. So the next complication that we'll talk about where efforts are taken intraoperatively to reduce the incidence is paraplegia. This is probably one of the most significant comorbidities associated with thoracoabdominal aortic aneurysm repair. Recent meta-analysis of 169 studies comprising 22,000 patients yielded the following sort of pooled incidence of this complication as broken down by Crawford classification of the aneurysm. So the risk of spinal cord injury was about 4% in patients undergoing type 1 repair, 15% in patients undergoing type 2, 7% in type 3, and 2% in type 4. It is notable that for high volume aortic centers, the risk is a lot lower in these instances. But probably the message to drive home is that the most significant risk factor for cord injury following open repair is the extent of aortic replacement, with type 2 replacement leading to the highest incidence where the entire aorta is replaced. Other risk factors include advanced age, intraoperative hypotension, the length of the surgical procedure, the acute nature of the surgery, and the presence of renal insufficiency. So we'll delve a little bit into the pathophysiology of cord injury in these cases. This is a diagram from Netter illustrating spinal cord perfusion, perfusion of the anterior spinal artery at the thoracic level. You see here's the aorta, and you see intercostals that come off and give off branches which provide collateral arteries to supply the anterior spinal artery. And this has been how anterior spinal artery perfusion is conceptualized for a long time, with there being one major collateral vessel called the artery of Adamkowitz that was thought to be provide the most flow. More recently, the conceptualization of anterior spinal artery perfusion has evolved. And what's used now is, the way it's thought of now is illustrated in this slide. So this is a cross-section of the cord, as well as the aorta and segmental arteries from a pig that's been injected with plasticine. And what you can see is that there's a broad collateral network of arteries that exists throughout the spinal and paraspinal spaces. Here's a coronal section illustrating the anterior spinal artery in the spinal canal. And again, this broad network of vessels that's known as a collateral network. So it's now thought that anterior spinal artery perfusion is supported by this collateral network that goes alongside the artery that derives its blood flow from intercostal arteries or lumbar arteries at each segmental level. So the pathophysiology of cord injury is thought to be related to exclusion of a critical number of segmental arteries coupled with hypoperfusion events, either in the intraoperative period or in the postoperative period. And that leads us to our strategies for cord protection. The first approach is to avoid permanent exclusion of a significant number or critical intercostal or lumbar arteries. And that's conducted typically through selective reattachment of segmental arteries guided by motor evoked potential monitoring. The other approaches include reducing the degree of ischemia by increasing cord perfusion pressure. So cord perfusion pressure is the difference between mean arterial pressure and CSF pressure. So the difference is increased by draining CSF, by increasing perfusion through distal aortic perfusion or left atrial femoral bypass, by conducting sequential clamping to minimize the ischemic time, and then by inducing hypertension in the patient. And finally, by allowing passive hypothermia or cooling of the patient, decrease cord metabolism. So in the rest of the talk, I'll focus on these three areas or these three strategies for spinal cord protection in these cases. So in 2010, a number of organizations, including the American Heart Association and the ASA, came up with guidelines for the diagnosis and management of thoracic aortic disease, and recommended as a class 1 recommendation the use of cerebrospinal fluid drainage in patients undergoing open thoracoabdominal aortic aneurysm repair. The largest study that demonstrated the efficacy of this technique. It was a randomized controlled trial from Texas Heart, comprised of 145 patients with type 1 and type 2 thoracoabdominal aortic aneurysms. All of the patients received distal aortic perfusion. All of them were allowed to become hypothermic during the case, and all of them had intercostal artery implantation. The groups are randomized to the presence of CSF drainage during and in the post-op period versus no CSF drainage, and found a substantial reduction in the incidence of paraplegia, 2.6% versus 13%. Specific considerations with lumbar drain placement typically target L4-5 level. It can be placed with the patient awake or asleep, with the patient seated or lateral position. The catheter that's used is a silastic catheter, similar to ones used by neurosurgeons, and inserted about 8 to 10 centimeters into the intrathecal space. The target is drainage pressure is to drain to 10 millimeters of mercury, and a cord perfusion pressure of 70 millimeters to 80 millimeters of mercury is targeted. So that's MAP minus the CSF pressure. In general, drainage is limited to about 10 milliliters an hour, but can be increased up to 20 milliliters an hour or greater if there's concern for cord ischemia. Drain insertion isn't without its own complications. This is a systematic review of 34 studies comprising 4,700 patients, looking at complications related to CSF drain placement. The total complication rate that they tabulated was about 10% incidence. 3.9% of cases, patients had posterior puncture headache, and 2% bloody CSF. 1.5% incidence of intracranial hemorrhage or subarachnoid hemorrhage, which carries with it a very significant morbidity and mortality in these patients. 0.9% incidence of persistent CSF leak, 0.8% incidence of epidural hematoma, and then 0.1 incidence each of drain fracture and meningitis. Next few slides, we'll talk about the strategy of distal aortic perfusion that's illustrated in this picture here. What it involves is essentially removal of blood from the left atrium, or removal of preload to the LV that's oxygenated, and infusion distal to the clamp to allow oxygenated blood or perfusion of the visceral organs, as well as the segmental arteries providing the cord, while the proximal anastomosis is underway. What this does is reduce significantly the ischemic time to those organs. In order to manage distal aortic perfusion, we rely on two blood pressures. We rely on the radial arterial line so that we can keep track of the blood pressure to the head. And then we rely on the distal blood pressure through a femoral arterial line to keep track of the blood pressure to the organs. And then here you see illustrated thoracoabdominal aortic aneurysm. A proximal clamp is placed, a middle clamp is placed above the viscera. There's a cannula in the left atrium that's taking oxygenated blood or the LV preload, and through the femoral cannula, infusing it back into the patient to provide perfusion of the visceral organs. The table below summarizes management of distal aortic bypass during these cases. The target map that we map is really no lower than 60, but ideally 70 to 80 distally, usually with flows of 2 to 3 liters a minute. So how do you manage the left atrial femoral bypass? Well, if our radial proximal pressure is high and our distal pressure is high, then typically you administer a vasodilator. Conversely, if the proximal pressure is low and the distal pressure is low, then that patient requires volume or tone. You can temporize with tone while you get the volume in. If the proximal pressure is high, but the distal pressure is low, then we just increase pump flow rates to provide more of that preload to the visceral organs. And then finally, if the proximal pressure is low, but the distal pressure is high, then we reduce the pump flow rate to provide more preload to the LV to perfuse the head. This is a database review, a Medicare database review of about 4,200 patients undergoing open descending thoracic and thoracoabdominal aortic aneurysm repair, in which half the cases employed distal atrial perfusion or atrial femoral bypass. And what they did was, after controlling for potential confounders, they found that the cases in which distal aortic perfusion was conducted were associated with a significantly lower mortality, as well as a significantly lower incidence of any complication, including pulmonary, infectious, bleeding, and renal. There have furthermore been other single-center retrospective observational studies that have shown a reduced risk of paraplegia or cord injury with the use of distal aortic perfusion for these cases. So the last strategy I'm going to touch on is motor evoked potential monitoring. So motor evoked potential monitoring is conducted to assess the integrity of the spinal cord and to aid in the detection of spinal cord ischemia with the goal of allowing the surgical team and the anesthesia team to implement strategies to mitigate the ischemic insult as it's happening. This diagram on the left illustrates the setup for motor evoked potential monitoring. The electrodes are placed on the skull, overlying the motor cortex, and then monitoring electrodes are placed in distal muscles, usually in the pollicis brevis in the hand and the tibialis anterior muscle. Electrical stimulation is applied to the stimulating electrodes, and then a signal is detected and recorded at the sensing electrodes. The presence of that signal and the amplitude indicate that the tract is intact. Here's an example from a case report of how motor evoked potential monitoring is used in practice. These are signals obtained from the left tibialis anterior muscle and the right tibialis anterior muscle during an open thoracoabdominal aortic aneurysm repair. This is at incision. You can see the signal deflections here. After the start of distal aortic perfusion, no real change. 5 minutes after the initial clamping, which clamp the aorta from just distal to the left subclavian artery to the T12 level. 30 minutes after clamping, no change. Once the clamp is moved, the proximal anastomosis is complete. Now there's clamp from the T12 level to the bifurcation. You see degradation in the amplitude of the signal. 2 minutes, further degradation. 3 minutes, the signal is pretty much gone. At this point, to address this change, 2 lumbar arteries are reattached and connected with systemic circulation. And this image illustrates that. In this case, specifically, this is thoracic or intercostal, but it's the same idea. In other words, a hole is made in the graft, which is then sutured around the origins of the vessels. The clamp is moved down so that those vessels are now perfused. So a minute after connection, no change. 15 minutes, slight deflection detected. 20 minutes, a little bit better amplitude. And by 30 minutes after reperfusion of those lumbar arteries, there's return of motor evoked potential signal. So the anesthetic considerations in the use of MEP are to avoid paralytics and avoid volatile agents. And the response to changes in MEPs include increasing the MAP, increasing distal aortic perfusion, distal aortic pressures, draining additional CSF, and then surgically reimplanting the intercostal arteries. This is a data slide from a meta-analysis of 16 studies, motor evoked potential monitoring during open thoracoabdominal aortic aneurysm, comprising of 992 total patients, which yield a pooled sensitivity and specificity of 72% and 96%. It should be stated that the data about motor evoked potential monitoring is a little controversial and a little variable in terms of the sensitivity and specificity. There's also some disagreement as to whether the interventions that are made based on the motor evoked potential monitoring make a difference or not. That being the case, most large centers that do these procedures do monitor for motor evoked potential, do monitor motor evoked potentials, and do proceed with interventions if there are any changes. Given the data, the guidelines really make it a class 2B recommendation, and that the procedure or treatment may be considered, and that the efficacy is less well established. So in summary, we did was just review the management of a patient for a very complex vascular procedure. Open thoracoabdominal aortic aneurysms are still necessary and are associated with significant morbidity and mortality. The focus of anesthetic surgical management is to mitigate the risk of spinal cord injury with CSF drainage, distal aortic perfusion, and intraoperative neuromonitoring. Thank you for your attention.